Hi everybody, John Herzenberg here, and what we're going to be demonstrating today is application of a circular fixator to gradually correct this angulated Blount's tibia. I've drawn in where the growth plate is, so we want to avoid that. Let's assume this is going to be a adolescent. We'll be applying a circular fixator with a 2/3 ring proximally and a full ring distally. I have a very formulaic way that I put my frames on tibias. We'll start with a 1.5 pin at the top, 2 pins in the mid-diaphysis to mount our proximal and distal ring. Once the rings have that temporary mounting, they're stable enough that I can then put in all my struts, and then we can see where the additional real estate is available for more fixation, because we want a total of 3 half pins at the top, and here we'll go with 2 half pins at the bottom, but in a heavier patient we'd use 3. We'll start by putting a wire parallel to the knee joint. I'll go just below the growth plate. I'm going from lateral to medial. So I've placed the wire just below the growth plate, and now I have to make a decision. Do I want to put my ring above the wire or below the wire? If I put it above the wire, then we occlude a little bit of the visualization of the knee joint. If I put it below the wire, as we put our half pin fixation, it's going to push our half pins more distally. And we normally like to make an osteotomy pretty high. So I'm going to choose today to put the ring above the wire so that my half pins are not so distal that we end up with an osteotomy too distal. So I'm going to ask my assistant to put a wire fixation bolt here. And these are universal wire fixation bolts. They will have both a cannulated and a slotted portion. For the first wire though, we always use the slotted position because you can always adjust it a tiny bit up or down. Once we're fixed, we'll put additional wires in. Let's tighten this one now. Now when we're tightening the bolts, we always have to hold the ring solid, very tightly. Okay, now I'll hold this side. I'm going to take the wire tensioner and slide it down until I get the appropriate tension, and then close it tightly. Okay. Now at this point we could still slide our ring side to side, and I'm going to show you a technique for cutting the wires without a wire cutter, and that's just bending it back and forth until it breaks. The only downside of this technique is you can't retension the wire, but that's rarely necessary. We've put the ring on correctly so that the numbers, the letters A, B, C, D are missing because it's a 5/8 ring. E and F are facing downward. And just as an additional check, it says distal side. This side says proximal side, so you can't make a mistake, or you shouldn't be able to make a mistake. Now, next thing we're going to do, I'm going to use 3 half pins, one in the middle, one anteromedial, and one anterolateral. For this, I need a 16mm bolt, and this happens to be a double pin cube, which is a bit stronger than the single pin cubes. I'll illustrate both. So this still has a little bit of freedom here for rotating. I'll ask you to hold that. And I'll take my drill bit and the drill sleeve, and I can rotate this on the bone. I don't know if you can see that on the film. Let's rotate the entire construct. I can rotate this up and down on the wire until it becomes parallel with the ring. And I can read the size of the half pin off of here, and it looks like we're at 40. For this pin, we're using a fully HA coated pin that has additional coating on the shank. So you'll notice that this has a quick connection, so we can use that very rapidly to apply this. Now, if I'm tightening the cube, I will need a 13mm wrench. Okay, hold the frame. And then the last thing we'll do is You have the tubular wrench. So now we're tight, and I want to make sure that this is placed perpendicular so that we don't have a procurvatum or recurvatum here. This is strictly a varus deformity, so this is perpendicular to the long shaft of the tibia. All right, last thing we need to do is to put our set screws in. So this is our provisional fixation. We've got, this is a stable ring block now. We've got a wire and a half pin, and it's fully stable. I mentioned before that I have a very formulaic approach to putting my tibial frames on. A transverse wire, spin it up and down until I get this perpendicular, then place a half pin. Now we direct our attention to the diaphyseal ring. I'm going to put this in the mid diaphysis. So if this is my ring, the ring also says proximal versus distal, so I'm going to make sure that the distal side faces distal. I'm going to put this on perpendicular to the long axis of the tibia. So this mimics our deformity. If this is where I'm putting the ring, I'm going to take a 5-hole cube and put this in the front. Why in the front? Because I know that this is going to be completely out of the way of all the struts. I'll hold this by hand, apply the 5-hole cube, and say, okay, that's where I'm going to put my half pin. So I can, mark the skin and say my half pin goes here with a 5-hole cube. Now I'll take my drill bit, load it up on the quick connect, and I'll have my assistant hold the bone like that. Now here, I want this to be right in the center of the bone, but bicortical. So I have to be careful not to be too medial or too lateral. And I want to be perpendicular to the bone. And that's measuring 30. So I'm going to take the quick connect drill out, put the quick connect pin in, and put my 30 pin in. So now I have this pin more or less parallel to the anterior pin. I'm going to mount my 5-hole cube on and set screw. Okay. And I'll take the ring, proximal side facing proximal, the distal side facing distally. I want the A-tab in the front. I need a 16mm bolt. And a 13mm wrench. Now this is not yet stable. It won't be stable until I add a second half pin. So I know that this half pin is out of the way of my struts because my number 1 and number 2 struts splay out this way. I know that this one's out of the way of the number 1 and number 2 struts. So now, just to be absolutely 100% certain that we'll be out of the way of any other strut, I'm going to come from the medial side and put a half pin on the medial face of the tibia. And when I put that pin in, I'm going to make sure that the ring is parallel to the shaft. So now I can wiggle this side to side until it becomes perpendicular to the shaft of the tibia. At that point, I'll add a second pin. I'll come from the medial side. And I have to be thinking about where my struts are going to be going. I don't want to take up these dotted holes, which will be for strut placement. Now, I could go down for additional fixation and stability. I could go down with another 4 or 5 hole. But for this purposes, at this point, I'm going to put a single hole because we have pretty good spread between the 5-hole cube and the 1-hole cube. That's a pretty big segment of bone. But we can later add a third pin, giving us even additional fixation. Okay, I'll take a 20. And a 13. Hold the ring, please. And I'll finish with a set screw. And that is our provisional fixation. We've got a single wire and a half pin and 2 half pins. Both rings are stable, they're not moving. At this point, our next job is to put in the struts. Why now the struts? If I want to put in additional half pins, let's say I want to put in an anteromedial and anterolateral half pin. Typical Blount's child is very heavy, we need good fixation. It's hard to know exactly where to put additional fixation until I know where the struts are coming. Once I determine the pathway of the struts, then I know where my free zones are for placing additional pins. So we'll stop right now and put in our struts. Let's talk for a minute about the struts. In this system, the struts come in a long, medium, and short size. Shorts we don't use too much, but we'll use mostly the long and the medium today. These struts are designed so there's actually 2 scales. There's a scale over here called the B scale, which allows you for rapid adjustment. That's great for fractures. And they have another scale, which is seen on the inside, and this is your gradual adjustment scale, your so-called A scale. When we're trying to decide where to set the A scale, where to set the B scale, I find it useful to start by putting the top of the strut in the hole. And we're on the A tab, and we have a special shoulder bolt for this purpose. And now we have to put the other end in the corresponding hole. And we go from A to F, and then we'll go from F to E, so forth. So we have to decide where to put this, and you have to anticipate what this strut is going to do. So this strut is probably not going to change much in length, but the way I have it set right now, it gives us a lot of room for lengthening, but not much for shortening. So I'm going to put it more in the middle so I can both lengthen and shorten, because once this straightens out, we may want to shorten it. So it's useful to anticipate where the strut's what it's going to do as you finish the correction. So this gives me about 12 or 15 millimeters of shortening and tons of lengthening here. So that's our number 1 strut. Now we're going to put in the number 2 strut, which goes from the A tab to the B tab. We have to decide. It's a little bit shorter on this side, so should we go with the medium? Looks like it will fit, or should we go with the long, which will just barely fit? Well, we have to anticipate what's going to happen to that strut. This strut is going to get larger as we correct the varus. So if I use the medium strut, it's not going to have any more excursion. We've bottomed out in our excursion. So better in this case to use the longer one fully shortened. So I'm going to put the long strut in. And let's see if it reaches. It does. This is a better choice than the medium strut, because this is going to give us a lot of excursion to lengthen. Now I'm going to go ahead and put in the rest of the struts. We're on the concave side of the deformity here, and so this is going to require some lengthening, so I would like to use a longer strut, but when I try to put the long strut in, it's just, even with it fully retracted, it's just a little bit too long. I have to force the frame, which is not good. So what I can do as a workaround is to find a different hole nearby where it fits more comfortably. And with this system, I am allowed to attach the struts to different holes other than the ones that are outlined in white markings. I just have to later tell the program that I did that. So now this fits very comfortably and very smoothly without any tension. And but you notice that I bypassed the standard hole and placed it on the inner mount of the ring instead of the outer mount. And that's where it wants to be. That allowed it, because it was a little bit too long to get in here, I made it into this hole, and now we just have to tell the computer that's where we put it. So I've completed placing all 6 struts, and all that's left to do now is the final tightening the struts are made tight to each of the rings, and they're still allowed to rotate within the ball joint here. Once I have all of them tightened down, then I'll take the numbers and put them on, and we're ready to go. So I've tightened all the struts down, top and bottom. I've put on the number tabs. 1, 2, 3, 4, 5. One more to go. And we have a tab for the B scale and a tab for the top of the strut shoulder bolt. The B scale is something we don't want the patient to mess with. So by putting the number tab on the B scale bolt, it prevents the patient from inadvertently trying to adjust that. Because if that gets adjusted, the whole strut becomes loose. And that, the only the patient's going to do is turn the A scale. So now I've got a stable frame, but we haven't finished with our fixation. We have a single wire and a single half pin, 2 half pins below. I want to add additional fixation. The reason why I wait until this stage to add the additional fixation is because now that I put the struts in, I see where my passageways are to put additional half pins in. Before I have the struts in, it's hard to gauge on this side where to put the anteromedial half pin, because I don't know if it's going to be in the way of this or not. But now that I see this, I know exactly where my free passages are. So we're going to go ahead and place on the medial side, we're going to use a 1 hole with an extension. By adding a plate, it's just going to push this down a little bit further than a standard 1 hole. So that's measuring 45. Okay. Now I'll take a half pin anteromedially. And a set screw. There's an option to come from below or also from the side. Here it's a little bit easier to come from the side. Okay, so I've got 1, 2, I want to add a third half pin. This is off of a 2-hole cube. This is off of a 1.5-hole cube. I could try to put a 1-hole cube here, but it might hit the other one, so I'm going to use the pin fixation bolt, which gets you right down onto the ring. We're just going to skim below that growth plate. $50. And a 10. Okay. Completed the fixation here. I'll add one more piece of fixation distally. So I need a 2-hole cube. It would be somewhere halfway between these two. And a 16 bolt. Thank you. And I'm coming from the anteromedial side. But now that I have the struts in, I can tell where my free zones are, so I can place these comfortably and they're not going to collide with the struts during the treatment. Another 20. And we'll finish it with a set screw to hold it in. I'm holding the cube with a 13 wrench, closing with a 10. And that is our completed fixation. I have a 5/8 ring proximally with 3 half pins and a wire, a full ring distally with 3 half pins, delta configuration, very strong. Now we also, as you may recall, started with a wire. In my experience, patients don't like this wire. As they move through the knee joint and flex and extend, this wire irritates the soft tissue. So you may elect at the end of the case to remove this wire and leave them with just the 3 half pins. That's sufficient. Alternatively, you can start treatment with the wire, and when they come to clinic a few weeks later, if it's bothering them, this wire can easily be removed in clinic. The next step in the operation is to do the osteotomy, which we're going to do very proximal, about a centimeter below this most distal of the proximal half pins. However, before we do that, it's incumbent to record the lengths of each strut and the type of each strut. So long, what the A scale, what the B scale is. So we're going to take a moment to do that. At this point, we're going to record the length of the struts, and within each strut, we're going to record what the A scale is. That's the adjustable scale. We can read that by this little marker on this scale. And the B scale, which is this line marker over here. The B scale stays rigid. The A scale is what the patient will move. And we have a pre-printed form that the nurse can fill out in the operating room as I call out the numbers to the nurse. First, we need to say strut number 1, 2, 3, 4, 5, 6, is it small, medium, or large? And then within strut number 1, 2, 3, 4, 5, 6, what is the A scale reading and the B scale reading? So we'll go ahead and do that. So at this point, I've recorded the strut lengths. We have 3 larges, a medium, 2 more larges, the A scales, and the B scales for all 6 struts. I also recorded that we're using in the proximal ring, we have a partial, a 5/8 ring. In the distal ring, we have a full ring. They're 155 millimeters each. We're going to do a proximal preference ring. Could go either way, but it's better to use the preference ring that it's nearer the deformity. I mentioned that this is a right tibia, and there are deformities in the proximal metaphysis. One last thing. You may recall that the number 3 strut was placed in a non-standard configuration. Instead of in the standard white ring hole, it was placed in a different hole because that's where it fit best. So we have to make a notation that the strut number 3 in the proximal ring is in a special hole. Looking at the anatomy of the ring, from the lower side, the distal side, we see numbers here that denote each one of these holes. The inner row, the holes are marked 5, 10, 15, 16, 17, 18, 19, 20. If we're putting them in special holes in the outer ring, they're 115, 120, 125, so forth. Our strut number 3 was placed in the inner hole, so that in between these two, so that was hole 15. We'll make a note of that. When we go to the computer, we can tell it that we have a special non-standard mounting for strut number 3. Now it's time to make the osteotomy, so I'm going to remove the strut number 1 from its proximal location. And that should give us enough instability in the frame that we'll be able to demonstrate that the bone is indeed completely cut, as evidenced by translation. Now, we could do an oscillating saw here in the laboratory, but that's not what we do in real life. In real life, we make multiple drill holes. I'm going to come from the top down and make a series of parallel holes that are parallel to this pin. I can go to the same entrance and 3 exits. And we can do another one. I'm making a few more holes than normal because I don't want the bone to shatter. These plastic bones have slightly different characteristics than normal bone. So I've made my series of holes. Now I'm going to take the osteotome and first come down the medial cortex. Then I'll come down the lateral cortex. And the osteotomy is now complete. Translates. And so I'll reduce it and put the shoulder bolt back in strut number 1. At this point, all we have left to do is to close the wound, put on dressings, and then we'll put the special reference ball markers on the proximal ring, on our preference ring, and take x-rays under our direct supervision so we know exactly how they're being made. In this system, we have to put on these 3 x-ray balls so we know what the mounting parameters are. The computer will calculate that for us. For the AP view, the balls go in the front, medial, and lateral. For the lateral view, we'll do something slightly different. So here's this for the AP view. And there's no ball here, but for the lateral view, we'll need to do that. The rule is that you don't have any balls resting on the x-ray cassette. So when we go to do the lateral view, we always shoot from medial to lateral, this direction, parallel to the joint. But remember, the rule is we're not allowed to have a ball on the x-ray cassette. So we'll take that off and we'll add the 3rd ball back here. This is a special x-ray extension used for the 5/8 ring. Allows us to put a ball back there. So for the lateral view, we're going to shoot from medial to lateral with this off because our x-ray cassette will be here, shooting this direction. So now we're ready to take our AP view. We've got no balls in the back, 3 balls in the front, anterior, a patella forward view because we mounted the ring such that the patella was directly in the front of the A tab. Now we're going to use the data from this case, this high tibial osteotomy, to create the program using the web-based software. So we'll start on this blue button on the upper right, create a new case. We're going to give it a name. This is a HTO, so we can just call it HTO Blount. And the date of surgery we said was 8/24. And we'll wait a week and begin the correction a week later, which will be 8/31. And you have the option of writing some case notes if you like, but not really required. So now we've created the case. We hit the blue button and the computer is chugging away, and we can see our case at the top says HTO. It's created today, which is May 27th, and we can view the details and we can advance to the next screen. So the first thing I like to do is select the bone. So this is our right tibia, and our osteotomy is very proximal, so we'll hit right tibial proximal metaphyseal osteotomy. And then we'll go up and say, select a preference segment, and since we put a ring on the proximal tibia near the deformity, we'll select the proximal preference. Next thing, we want to describe the main deformity on the AP view. It's varus, so we'll hit the varus button, apex lateral. And on the lateral view, there really was no deformity, but I like to put in a little bit of procurvatum on just about every tibial lengthening because it tends to develop during the lengthening, so we might as well do some prophylaxis against it. Now we'll hit this lower button on the right called Save and Continue, which brings us to the next screen, which is going to be the hardware screen. Now we're on step 2 of 6 steps. Selecting the hardware, that's simple. So the ring we used was a partial ring, and it was a large bone ring, not the baby frame, and we used 155 millimeter 5/8 ring. For the distal ring, we used a full ring. It was, again, large bone. You can't mix and match, by the way, and it was 155 millimeters. We didn't use any rotation. If you happen to do a lot of rotation, you have the option of rotating your frame, but we applied the frame pretty close to anatomic. If you're within, say, 15 degrees of the anatomic, you don't really need to make any changes. Next thing, we want to select our struts. So in this particular frame, all the struts were large except for number 4, so we'll hit medium for number 4. And before we go, leave that, we're going to go up. We did use a non-standard mount on one of them. You may recall that strut number 3 was placed in a hole that was not standard, so we're going to hit that yellow line, strut number C, and move it to hole number 15. And distally, it went to hole number 109, which is the normal place. So this is just the way we told the computer that we had one strut that was off. It populates all the other struts automatically. Now, at this point, all we have left to do is to put in the different lengths of each strut. So we have the A scale and the B scale. So I'm just filling these in. The A scale, just to remind you, is the adjustable scale. The B scale, which is coming up next, is the fixed scale. So the B scale numbers are listed here: 8, 10, 0, 18, 18, and 1, 4, 14. So everything else has been calculated by the computer. All the holes that are listed here are the standard holes, so you don't need to write those down. We did have one non-standard hole for strut number 3, which is in hole number 15. But all the other numbers, I didn't put those in. The computer knows that those are standards, and so they just put them in. So now we'll go to the blue button, Save and Continue. And we'll do the AP planning first because it's primarily an AP deformity. So next thing we're going to do is get into step 3 of 6 steps. This is where we upload x-rays. And our choices are uploading the x-ray or click and paste an x-ray. I've saved the x-ray on my computer as a JPEG, so we're going to upload it that way. We hit the upload button, and it's listed here as HPO, HTO, AP, DID. And we're importing that, and that's our x-ray. Now, we do have the option of changing it. If it's upside down or if it's rotated, we can do various things. We can flip vertical, flip horizontal, rotate it. But I like the way this looks on the screen. This talks to me, so we'll just keep it as is. So now we have a laundry list of things we have to do here on the left side, and it's just one by one. So first thing we're going to do is define the proximal ring. Why do we define it? We have 3 balls that we put on it. Remember those? There's the first ball, the second ball, and the third ball. And we go in that order. The next thing, step number 2, it wants us to define the proximal joint line. Now you notice that on the diagram on the left, the 1 is on the lateral side of the joint line, the 2 is on the medial. We must go in that order. So you click lateral to medial, just like the diagram says. Step number 3, they want a center point. So I would move the center point a little bit more lateral, and there it is. Now, if I don't like that center point, I can change it. I do have the option of using these caret arrows and adjusting the position of the center point. And just above it, there's a printout that tells me where we are, but 50% is really what you like to see, so we'll just keep it there. Now, you notice that when I did the center point, 2 lines appeared, a blue line and a black line. The black line is a 90-degree line relative to the joint surface. The blue line is our 87-degree. So you may decide that in this particular case, you want to change that to 86 degrees or to 85 degrees or to 90 degrees. Now, why would you want to do that? Well, ultimately, we want the tibia to match the femur. We don't see the femur in this x-ray, but we know from our pre-op planning that a femur may have an LDFA of anywhere from 85 to 90 degrees, or maybe even more. In some Blounts, they get some varus in the femur. So let's say we had a 92-degree LDFA in the femur. We might want to make a 92-degree MPTA in the tibia. So we can hit that, and now the blue line is slipped over. But for this purposes, let's leave it at 88, and we'll apply that, and so that's what we're going to try to hit. All right, where are we? We're up to the distal bone segment line. So we draw a line from 1 to 2. It should go from distal to proximal. We don't need to see the ankle as long as you draw that line. And I recommend that that line cross all the way up. So there's an actual intersection point between that red line and the blue line. As soon as we click on it, automatically the computer draws a transverse bisector line, which is the green line. That's where the hinge point will need to be. So if we put our hinge anywhere on the convex side of that, that will automatically realign the bone. Now, I want to point out the difference at the osteotomy between the red line and the blue line. That difference, that 12 or so millimeters here, is the amount of translation, of obligate translation that you will see when we finish the correction. So you can kind of preview in your head how much translation is going to need to take place, because we're rotating around the intersection, which is at the level of the almost the joint line in the epiphysis. Next thing the computer is asking us, step number 5, is to draw the osteotomy, and it's very important to look at the numbers here on this screen. It goes from 1 to 2, from lateral to medial. We can zoom it in to take a closer look at it, and now we can draw that from lateral to medial, and now the computer knows where the osteotomy is. Step number 6 is our proposed pivot point. Well, the pivot point we know from Ilazarov's work has to be somewhere on the transverse bisector. How far? The farther out you go laterally, the more lengthening you'll get. We're not after a ton of lengthening, so we'll put it somewhere near the lateral cortex. And then the next step, the computer wants a rate-defining point in the bone. In other words, when we do a correction, what do we want to go a millimeter a day? And usually it's on the concave side, in this case, the medial border of the tibia, so I'll put a point there. If we had a soft tissue structure that we were concerned about, like the perineal nerve, we'd put it, but since we're going from medial to lateral, from varus to valgus, we don't have to worry about that. So the RDP bony and the RDP soft are the same. The computer has now calculated our angulation. It's calculated it at 20 degrees. And so we're ready to go to the next step. We'll hit save and continue, brings us to step 4. Step 4 is the computer is going to ask us to look at the lateral x-ray. So we're going to upload the ML, the lateral x-ray. And we'll wait a minute while the computer brings that in. You notice how we imported the image facing the same direction as as we would normally put up a right lateral of the tibia. So the anterior is on the left side of the screen. Now, again, if we don't like this x-ray, we can adjust certain things. We can change the rotation. We can flip it. But we're not going to do that because we actually liked it. It's a nicely done x-ray and it's pointing in the right direction. All right, so we're going to go through the same steps we went through. So let's look at this diagram on the left. Notice there's a 1, a 2, and a 3. And we're going to do the same order here, 1, 2, and 3 as we go from anterior to posterior and mark those 3 reference balls. Step 2 wants us to draw the proximal joint line, which is tilted down about 10 degrees. And that's, I think, where the proximal joint line is. Next thing it wants us to draw is the joint orientation line. So we have to pick a point, and normally it's about 20% back. Here I did it at 28%, so I can adjust that to make it 20% and apply that. And I can also change that angle to make it an 80-degree angle, for example. And lo and behold, when I look at it, if I drew an 80-degree posterior proximal tibial angle, that blue line goes right down the center of the bone. So what this is telling me, folks, is that there's no sagittal plane deformity. Now, I may decide to override that, but at this point, we still have to put in the distal bone segment line, but essentially it's the same as the blue line. So we can draw a distal bone segment line going from distal to proximal, and clearly there's no deformity here. Next step, it wants to mark the osteotomy. So we'll draw a line from anterior to posterior to represent the osteotomy. And as soon as we did that, the yellow line appears, which is the equivalent of the transverse bisector that we saw on the AP view. And it places that automatically at the same level as the major deformity, which is the AP. So if we are going to correct some procurvatum, we want our apex, we want our center of rotation to be a little bit anterior. So as soon as we do that, we have to now put in the RDP bony and the RDP soft. So what will we put here? For the bone, the part that'll be opening the fastest is posterior because we're going to be correcting a little bit of procurvatum that may develop. So we're going to put a click there. And for the soft tissue, I just do it in the same place. And now we'll review and everything looks okay. We're going to go on to the next segment. Now we are up to the corrections. So this is step 5 out of 6. Okay, so let's see what this is like a little spreadsheet, guys. So the first thing, we're going from varus to valgus. That's correct. And the computer has calculated 19.6 degrees. Now, if I want to, I can override that. I just will put in, say, 20 and hit tab button, and it changes it to 20. We said there's basically no sagittal plane deformity, so the computer calculated 0.2 degrees. But if I want to prophylactically correct some procurvatum, I'm going to change this to procurvatum to recurvatum and put in 1 degree. So what I'm doing is I'm telling the computer I want to make 1 degree of recurvatum anyway. Next thing is the translation. So because our osteotomy is not at the level of the apex of the deformity, the cora, the computer has calculated that we are going to get 12.5 millimeters of translation, which we saw on our AP x-ray. On the lateral x-ray, none. Lengthening, the computer has done the calculation. It's calculated that if we put the hinge where we did, we will get 10.5 millimeters of correction at the midpoint of the osteotomy, in the middle of the bone. Axial rotation, we said there's none, but here's our option. If we wanted to, we could put some in, but since there's no rotation in this bone, we don't need to. The default correction here for the millimeters per day is 1 millimeter per day. And if we do this with this deformity at 1 millimeter per day, the computer has calculated for us that it will take 24 days to get the correction. Now, I might want to make a little change here, guys, because in my practice, I like to first distract before I do the angular correction to help disengage the bones so they don't mash into each other and somehow stop the correction. So what I'm going to decide is step 1, we're going to do no angular correction. I'm going to make that 0, and then I hit the tab button. So automatically the computer is making the angular correction of 20 degrees, step 2. Then the translation here is 12. I'm going to change that translation to 0, and we're going to make the translation part of step 2. And last, the lengthening, we're going to keep the same. So basically what we're telling the computer, we want to first lengthen by 10.5 millimeters. And then in step 2, we want to do the angular correction plus the translation. So the bone will disengage by 10 and then do the rest of the correction. Now, as we updated this, you can see also step 1 is going to take 11 days and step 2 is going to take 18 days. So we do prolong the treatment a little bit in this scenario. Now we can watch on the computer animation that we first see distraction along the axis of the reference segment, the preference segment. And step 2 will be the angular correction and the translation. And you can look at that from different directions. This is the medial lateral view, lateral medial, PA. So it's a bit of a preview, kind of fun. We'll save and continue. And now this brings us to what the patient wants to see, and that's the schedule. So we'll start at the top. And the date of surgery we put in, the correction start is a week later. We could change that at this point if we wanted to, but we'll leave it the same. And this is the next thing it wants to know is how many adjustments per day. So we might as well take advantage of the fact that we can break it up into small segments, and that will be healthier for the bone and less pain for the patient. So let's do 3 times a day. There'll be 3 adjustments per day, and we'll save those changes. And now the computer gives us two schedules, one in millimeters and one in clicks. The clicks is what the patients are going to see. They're going to see that, for example, on day 1 in the morning, strut 1 does a click, midday does a click, and evening does 2 clicks, strut 2, 1, 1, and 1, and so forth. Now, as we get down lower in the schedule, we may see some negative clicks going in the other direction. That means these are supposed to go counterclockwise, so that when the patient sees the minus number in front of the click, he knows to turn opposite direction. Now, I like to give the patient both the millimeter schedule and the click schedule, and I tell them at the end of the day they should look at the number and make sure they're more or less on that number. So strut number 1 should be 162.25, strut number 2, 143.25, etc. And then we'll go down and do a printout of the schedule. We can label it, and this is what it looks like in a PDF format. You can mail that to the patient, you can print it out, put it in the chart, you can print it out and give them a copy of it, and you can also do the same thing with the click schedule. So this is what the click schedule looks like as a printout. And there you are. That's finishing the correction schedules, and now we're going to take this downstairs to the lab and do the correction on the bone. While we're looking at this schedule, if at any point in the middle of the schedule we wanted to make a change, we can hit one of these blue buttons. So if the patient returns on a certain day, we can hit the blue button and we can make changes in the schedule to slow it down, speed it up, and so forth. This now takes us back. Now we're in a residual schedule. It takes us back to our original program, and then we can do modifications. For example, if we want to change the rate, that's the most frequent thing I want to do. We'll slow it down to 0.75 and hit save and update, and it'll recalculate how many more days are left on the schedule. So it's going to drag the schedule out a little bit longer because we're slowing things down. And then we'll go to the final schedule and print it out. Now this is a new schedule from that mid portion. It's a new rate of correction, and so we can give the patient a new schedule. At this point, we've done our program. We did the correction, and now we can see how well our program did. See a separation because we programmed in about 1 centimeter of lengthening. We can see that the osteotomy has translated a little bit. That's obligate translation because our cora was proximal and our osteotomy was a couple centimeters distal to that. See that the tibia is centered, the tibial joint space is centered directly over the shaft of the tibia. So overall, we're happy with the AP view. If we look at the lateral view, we have an appropriate 10-degree tilt of the proximal tibial plateau posterior. So it's not procurvatum, it's the normal 10-degree tilt. So overall, quite good. I don't think we need to do any residual corrections. However, if we found that at this point the limb was short, we could run a residual program to add some additional length. Also, if we found that now that the leg is straight, if the patient had a torsional deformity, this would be a great time to program in torsional correction as a residual program.